As we come to this today, we want to really hear from the panelists and the speakers, but just some very quick highlights that, of course, neglected tropical diseases, as we say, are actually neglected people. We know that there is, of course, our target to ensure we eliminate them, and there have been many successes that we must celebrate. Those successes are reflected in the countries that have recently been declared at least one NTD free, including my own country, Kenya, recently, but many others, including the ones that have more recently within this year, countries like Senegal and others. And we are going to hear a little more from our speakers on these countries and the successes that they have achieved. NTD burden is a big problem, and we know that it's been supported significantly by funders, by governments, by private sector, led by communities at the country level, and we continue to address it, though we are a long way to achieving our SDG goals of at least 100 countries to eliminate at least one NTD. I know that 57 countries now across the world have done so. In Africa, I think it's 27, which is the burden is. Please remember that the burden of NTDs is very well mapped against poverty, absence of water, sanitation, and more recently also being accelerated or exacerbated by the climate crisis. And I know there are questions around how we can address that. So we need to address this issue today as we discuss. We thank the support of the End Fund in this leadership of this conversation, and also the Gates Foundation that has enabled this conversation to happen, and all the speakers that will be here. So I would like, without much ado, because mine is not to be the one to speak, it is to invite others to speak. And therefore, whereas I have my own views, I would like to also learn from those who are speaking to us. And I would like to open by inviting Dr. Sultan Matendechero from the Ministry of Health in Kenya. And Sultani has actually been on the forefront of NTDs for a very, very long time. He is one of those people who have been synonymous with NTD response, but also has been involved in negotiations for the international health regulations at WHO. So very well plugged to the global health agenda. So Sultani, from where you stand, what is it we need to do to ensure that the neglected are no longer neglected? Not only the diseases, but the people themselves, from where you see it at the Ministry of Health in Kenya. And congratulations for being declared trypanosomiasis free. Over to you, Sultani.
Yeah, thank you very much, Dr. Gitai, for this good opportunity, and by extension, also, I think I really want to thank Amref Health Africa and the partners, Gates Foundation, other partners like the End Fund, and I'm sure there are others, for putting this very important conversation together, especially at this time. And I would say that even the way in which the topic has been coined is very apt, because indeed we are in a changing world, and this has now gone beyond the neglected tropical diseases. The entire public health system is experiencing a big shift, especially in terms of the funding infrastructure, framework. And definitely we have come from a place where neglected tropical diseases have been the most affected. And we expect that if we don't do anything, then we are going to see a much bigger effect on the NTDs. Now, I think from where I sit, NTDs are just generally, and you have put it very clearly and very correctly, NTDs are just generally diseases of poverty. That is where everything actually comes to be, because you'll find that there's a very clear correlation. If you go to the global north, where the majority of the people are not, they are quite economically empowered compared to those in the global south, you will rarely come across NTDs. But it also comes down even to the global south, where you find that whereas we have quite a bit of NTD burden here, the people within the global south who are economically empowered do not suffer from the NTD. So it clearly tells us that poverty is the main entry point here. So we have been able to demonstrate that the problem with NTDs is that there is no return on investment. If you decide to invest in research on NTDs, for example, then you should expect that you will not really get a return in terms of the kind of resources that we expect to get by investing in research, for example. If you invest in coming up with new tools, whether they are medicines or whether it is diagnostics or any other health products or technologies, it is very unlikely that you'll be able to get a return on investment. In fact, you are likely to be asked to donate whatever you have come up with, whatever invention you have come up with. And so that keeps people away, who would have come up with inventions to help us eliminate these diseases. And that now actually rubs into our face the fact that there is that poverty disease cycle that we have to break. Because the more poor we are, the more NTDs we suffer from, the more poverty it brings. And so we will never get out unless something is done. So, Dr. Gitai, you said this in the beginning. It is not possible, and this is probably, I don't know the nth time I'm saying this, it is not possible for countries to develop economically when they are heavily endemic with NTDs. That is a fact that we know. It is not possible. So countries really need to start looking at NTD control and elimination as a very important economic strategy, because we will never get out of this problem for as long as we have the kind of disease burden that we are seeing with regard to the NTDs. So what have we been trying to do, and what should we really strengthen? And I'll be listening out as we continue with this conversation to see how we want to be able to improve access as we move forward, because in this changing world, we expect that that is going to take a hit. Number two, I would like to hear a little bit more about how we are planning to make sure that governments are now at the center of this NTD programming, because we have seen that external support has been over-relied upon to be able to drive the agenda, especially in the developing countries. So improving and strengthening government ownership, advocacy, especially at policy level, coordination and partnerships which are government-led. Number three, I am very keen to hear about the plans we are having around improving our planning for results, because most of the time we just muddle through. So we really need to see how do we sharpen our planning for results, resource mobilization, which is now at the center of discussions, and financial sustainability. I think in Kenya, we have done quite a bit in terms of organizing our resource mobilization. And that is why we have seen very good results, like the one that we experienced recently in being declared free of human African trypanosomiasis. And then finally, I'll be very keen to listen in to hear about our plans for surveillance, monitoring and evaluation, research, both operational and also scientific, and in general, just how we plan to manage our data, because we are collecting so much data as we continue implementing interventions around NTDs. But I know that we are not using that data effectively to enable us to plan better and to make better decisions towards elimination and control. Before we started, Dr. Gitai, you told me that I just have 6 minutes, but then you took another 10 minutes. So I want to stop at that point so that I can donate 1 or 2 more minutes to you, because you're my friend. Thank you, and back to you. And kindly unmute. We can't hear what you're saying. We can only just see you.
Yeah, you are. Thank you.
Thank you.
So thank you for donating your 2 minutes. You're well known for community service and philanthropy. So thank you, Dr. Sultani. But before you go, a very quick, how are governments, or is your government responding to the climate change crisis that's actually exacerbating the burden of NTDs? Anything to say about that?
So we are in a very interesting time when our president is very keen on issues around climate change. So number one, We are playing a very big part in trying to establish carbon sinks, where we are planning to do 15 billion trees by 2030. And as a State Department, Ministry of Health, State Department for Public Health, we have a target that we are really doing well in trying to meet, together with the rest of the government in being able to conduct that massive reforestation. Number two, as a health sector, we are also really trying to see how we can mitigate contribution to the emission of greenhouse gases. We know that we do quite a bit of those. About 6% of the total comes from our sector. So we are really trying to see how we can be able to go green and reduce on that. Number three, we are aware that climate change is responsible for some of the patterns that we are seeing shifting in very many diseases, especially the vector-borne diseases. And some of the NTDs are actually vector-borne. Recently, we had an outbreak of chikungunya on the coast. And so apart from just sharpening our disease surveillance systems, our preparedness, and our response mechanisms, including vector control, we have been very deliberate and intentional in trying to also mitigate the climate change level, so that we can be able to reduce the impact of climate change and also to contribute to mitigation. So we are really aware of that, and we are very specific in trying to make sure that the NTDs that are driven by climate change are also not left behind. Thank you.
Thank you. Thank you very, very much. So we'll now move on to the panel session, reminding all the 700 of us who've joined that there's an interpretation button at the bottom. You can choose either French or English. And I now hand over to the excellent, eloquent Dr. Ebere Okereke, who is the Chief Programs Officer at Reaching Last Mile Foundation. Ebere, my dear sister, over to you.
Thank you very much, Gitinji. And first of all, accept the condolences of the Mohammed bin Zayed Foundation for Humanity on the tragic loss of your staff just the other day. We recognize how difficult it can be to actually keep going in the face of such challenges. I'll also take the opportunity to mention that Reaching the Last Mile is now the Mohammed bin Zayed Foundation, but our commitment to the elimination of neglected tropical diseases remains very strong. We are a key partner in the Reaching the Last Mile Fund, which is has the ambition to accelerate progress towards elimination of onchocerciasis and lymphatic filariasis across Africa by 2030. That's just one of the programs that the foundation supports in the elimination space. We have been a long supporter of efforts to eliminate guinea worm from the continent, and have been an advocate for polio eradication for a long time as well. So on the basis, it's an honor and a privilege to co-moderate this session with my brother Gitinji. Him and I have done this many times in the past, and we have fantastic speakers, panelists that we will be introducing shortly. For us to use the time we have most efficiently, I will be brief in introducing them, and urge you to look them up in the conference material that has been, the webinar material that has already been shared, so you can get further information on them if you so wish. We will take a few questions with the panelists first, and then, as Dr. Gitinji said, you will have the chance for your questions to be picked up through the Q&A, as well as the ones you've sent in advance subsequently. So I will start by introducing the women first, because I am female and I am an advocate for women first. So it's my pleasure to introduce Dr. Clara Jones Mwansasu, who is the NTD Program Manager in the Ministry of Health in Tanzania. She leads Tanzania's NTD strategy and has extensive experience in managing elimination programs across the piece. Dr. Clara brings a strong and deep understanding of the realities on the ground at national level, and as well as how national programs interact across in regions and continentally. Then second panelist I would like to introduce is Onome Diposa Osadolo. She's a senior immunization specialist for UNICEF's East and Central Africa Regional Office, and her expertise is in strengthening health systems. She has over 20 years in that, It currently supports 21 countries in improving access to immunization, which is very relevant to neglected tropical diseases because the challenging populations for immunization reach are also those same neglected poor communities that are bearing the burden of the residual neglected tropical diseases. And finally, last but not least, it gives me great pleasure to introduce my brother, Dr. Solomon Zewdu, who is the CEO of the End Fund. Solomon leads the End Fund is the only private philanthropic initiative that is dedicated exclusively to eliminating the 5 most common NTDs. He has a long track record of working in public health across the continent and in philanthropy and resource mobilization in supporting public health initiatives on the continent. And so I'd like to welcome all 3 of the panelists and say thank you for your time. And I'm just going to open up to give you a minute to reflect a little bit first before we go into some specific questions. So we are aware that this now, and I'm at risk of sounding, very cliche, we keep talking about pivotal moments all the time. We have a lot of pivotal moments in health generally. A few years ago, the pivotal moment was COVID. But the current pivot and the current focus of attention is one of a global reduction in health investment, particularly donor-led health investment. That has created the challenges that have been exercising minds and politicians and health professionals across the globe in recent months. So I'd like to open up by asking our moderators to actually reflect on, from where you are, from your perspective, what you do. How is this transition? How is this challenge to move away from donor dependence to more domestic resources for health? How is that reflecting in your space? And I will start by putting that question to you, Dr. Clara.
Thank you very much, Doctor, for this really opening and setting the ground. So I'll start by extending the appreciation to Amref, Gates Foundation, End Fund, and all who have worked really hard to put this webinar together. Now, back to your question where you said from where I sit as a program manager, how is this transitioning showing up? Back in Tanzania here, the transitioning from foreign aid to domestic ownership has been a key theme in Tanzania since 2021. And so this is not really new, only that at this particular moment, it's like it has been a bit accelerated. So since 2021, we had developed our sustainability plan and we set a very overarching target of achieving or attaining 60% for NTD intervention, which like 60% domestic financed from own sources by 2026. So following now the current change in funding landscape, and as we are navigating through these changes, in Tanzanian context, the government has prioritized NTD by including them in the national health plans and creating a dedicated budget line. For instance, recently in April, when we launched the Tanzania health sector priorities, NTDs, for the first time since the creation of this word, I would say, NTDs are among the 10 priorities. And now we are seeing local government authorities increasing their share of funding on NTD interventions, with some already reaching the 60% threshold for financial support from their own sources. And if we look back in 2024, when we did the financial analysis, we were at 25%. And this is only for operational cost, doesn't add the commodity cost. So when we look at the current change, the sudden change, we jumped from 25% in 2024 to above 6%. So the main change now, what we have seen in terms on how we collaborate with the global community, is the sudden shift and focus on domestic resource mobilization. We are witnessing the engagement of the partners and global communities in assisting endemic countries identify strategies for continuation of services through enhancing domestic resource mobilization and integration. And this one is actually providing a path to sustainability. Of recent, we have witnessed how WHO has worked with member states to identify gaps and come up with mitigation strategies just to ensure that there is continuation of services. So in general, this shift is both a challenge, but to us at the ground, we see it as an opportunity which is pushing us to find more efficient ways to deliver services while we safeguard the progress we've made. Back to you, moderator.
Thank you very much. Thank you very much. And I'd like to sort of, I'm sure, join others in congratulating Tanzania on being on the front foot in taking ownership and building on domestic prioritization for neglected tropical diseases. So that's a very welcome approach. So moving to you, Onome, you're with UNICEF. UNICEF, the whole United Nations ecosystem is also facing this challenge that we've reflected on in changes, not just in the financial situation, but in the entire geopolitical approach to global health initiatives and to investment in through multilateral agencies. So again, taking from your perspective, what's the challenge? What's new? What's particularly concerning, and what are your approaches? I'm particularly interested because the UNICEF is a key partner in terms of procurement, in terms of logistics for a lot of public health initiatives. So as has been mentioned in the introduction, the neglected diseases are usually at the end of the line for everything. So what are we doing to change that narrative? Over to you.
Thank you very much, Dr. Ebere, and thank you for the invitation to this auspicious occasion. As you've said, I work in immunization, and for us in UNICEF, we wear the primary healthcare hat, looking at immunization as an entry point to primary healthcare and supporting countries in strengthening that. The immunization space had historically, if you compare it to the neglected tropical diseases space, had historically had more attention, more interest, more funding. But regardless, funding was inherently scarce, and of course getting scarcer as we speak at the moment. So in the last 1 year, 6 months, we've seen issues around, I like to use the word compromised integrity, but in some cases it's been actual disruptions around countries' abilities to prepare for emergencies. Surveillance systems and outbreak detection systems are quite well disrupted. Service provision is getting poorer. You called out the fact that UNICEF is that principal agent in the procurement of vaccines and related commodities and other health commodities. But then those commodities are either co-financed by governments or principally financed by governments. And so there have been issues around financing, health commodity financing. The workforce, with the reductions in the numbers of staff across a couple of UN agencies, I think we've all seen the statistics over time. So that reduction in the numbers of staff that are able to provide technical assistance, as well as reductions in those government positions that were historically funded with partner support, has also been a major deterrent to program progress. But the other thing we have also seen, and it was great to hear Dr. Clara speaking, there's a rise in domestic resourcing. Countries are thinking about innovative ways of financing their programs. And in parallel, governments are now in the driving seat, taking ownership for their programs and making 3 decisions that I see quite frequently in most conversations I have today. That's prioritization, deciding what is the new thing we should bring into our programs. There's optimization, which is how do we maximize the utility of the interventions that we are actually keeping? And then there are actual trade-offs where governments are coming to the table, even in the vaccine space, and asking those critical questions like, what vaccine do we introduce now? And what is the trade-off we should make in introducing this vaccine? When governments are talking, for example, we're talking about malaria vaccine introduction, there's a broader space to malaria prevention end to end. And governments are starting to ask that question, is this the right time? So for us, we are seeing government ownership, domestic resources are shoring up. And at the same time, governments are in the driving seat making some critical decisions. Thank you.
Thank you very much. It's very encouraging to hear about national governments stepping up and putting more investment in health priorities, and particularly being pragmatic and realistic in prioritization and what trade-offs that they make. Taking that sort of focus and going back to the dependency on donors has been a hallmark of neglected diseases for a very long time. In fact, the foundations of some of the elimination programs we have is based on donated medicines, as well as funding for the actual delivery of these programs by donor partners, now both in terms of private sector, philanthropies, pharmaceutical, as well as bilateral aid programs. So, Solomon, your organization, the End Fund, is about pooling resources, drawing resources to build up capacity funding for neglected diseases. What's new? What's challenging? What's the approach that you're taking in response to this current crisis that we're talking about?
Thank you, Mabera. So really great to see you on the call, as well as Dr. Gitinji. Always good to be among friends. Let me just start by saying that now to extend our deepest condolences on behalf of the End Fund and the community of donors on your loss, Dr. Gitinji. Our partnership continues to leverage each other. And when a loss on your side takes place, it's also a loss for all of us. So please accept our condolences to the family of the deceased, and looking forward to continuing to work with you. And kudos to you to getting started back up again. Like you said, you indicated initially that, the mission must continue. So having the strength to come together to really start, back services is huge, and we totally appreciate, and we're with you on that one. And secondly, really appreciating the invite as well. This is a great opportunity. I'm in transit, and I wasn't about to miss it, so I'm just a few hours, about an hour out from where you are, and in Ethiopia, in transit to Dakar. But I did make sure that I penciled in this session, and given the attendance that we see on the call, this is an amazing opportunity for us to express the current need and the pivotal moment that Dr. Abere was mentioning here. We indeed have had many of them, and this is one of many. The End Fund, as described, is the only global health platform that actually aggregates philanthropy funds as well as corporate donations and funds to laser focus on NTDs only. And out of all the NTDs, we go with 5 or 6, depending on whether you want to split the deworming activities that we have. But really with a focused agenda of elimination by 2030 and a little bit beyond that. Of course, hits like this do impact our ability to move forward at the speed and pace that we've been looking for. The conversation like today's, where we see countries and agencies stepping in to really look at what impact has happened, is the beginning of the healing process, if we want to consider this as a big hit and a pivotal moment that has had repercussions across the world and across the communities that we serve. For us, we've always, at the End Fund, 12 years in, we recognize that philanthropy money of corporate, donations are catalytic investments. They're not here to replicate or take away the responsibility for member states and communities to step in. We have been able to be successful in what we do because of engaging communities and engaging countries. Where that fertile environment ecosystem does not exist, we don't particularly have any traction. Hence, we don't even have the opportunity to move the needle the way we would be able to move or promise to move for the generous donations that we connect from all over the world. I'd like to emphasize here that it's not just about what we do and bringing global north resources, but it's also what we leverage on existing resources and continents. Continent is always, I'd like to make sure that we indicate here that there's every country in Africa has an opportunity and a commitment to putting together their health financing. So undermining the fact that already exists, and particularly talking about efficiencies in dollar amounts or effects or opportunities that exist on the continent is something that we don't want to ignore as we particularly talk about the catalytic opportunity that we create with foreign assistance. And we've seen this happen quite effectively in the last 6 months. We've seen it in at least one that comes to mind. When this happened, the WHO, Africa CDC, and all other partners actually came together with all member states, with the African Union leading the initiative to convene all 54 member states. And out of the 54 member states, 50 member states actually showed up in Ethiopia for 4 days to really distill down what the continental framework should look like for elimination of NTDs. This is a momentous event for us, make sure that we understand that we're planning around an actual disease burden and a financial burden that's quantified, which actually really changed the tide on dependency on foreign aid to drive the agenda of elimination versus really owning the data and the opportunity to design on the continent and leverage global goods and global opportunities to further existing diseases and existing data sets that we understand on the continent. And it also has helped us focus on a community. Earlier on in both the opening remarks and that's been mentioned, this is a community level engagement that we need to cultivate. NTDs for us, and it's been mentioned many times, it's an economic discussion, not just a health discussion. But beyond the economic and health discussion, I think we really need to talk about the basics in healthcare. Health systems are at the center of this. And I'd like to challenge all of us here to understand that as we look to eliminate NTDs, we're also setting the stage in both the behavioral and the systematic approach of we are capable of eliminating diseases, which basically tells us that we're also capable on the continent to actually start looking at the more sophisticated disease burdens and disease processes that we have not been able to, if we're able to solve for the NTD problem. Beyond that, I think it's pie in the sky. I challenge this and I say this in many times. If we can't do the basics, then, infant mortality that is stagnant and other diseases that I think require a lot more, attention are farther to reach than they are if we're able to solve our NTD problem. So over to you. Thanks for the opportunity again.
Thank you very much, Solomon. And that was a really comprehensive and reflective response. And you ended on a topic that I think is really relevant. And I would like to jump from there to some further questions to the panel. You talked about primary health care and having the system that is critical for any disease elimination that we might aspire towards. And we have, as part of the response to the narrowing fiscal space, there's been a lot of talk about integration. How do we integrate the agenda, the programs for disease elimination into either between programs and within the health system? We know that one of the challenges and part of the vulnerability in our health system is this over-dependence on vertical programs, not just for NTDs, HIV, TB, malaria, those big challenges about and the move has been to suggest that in addition to mobilizing more resources to expand the fiscal space, and we'll come back to your views on that we should be looking at how we integrate the elimination programs. And we know that even when you have eliminated the disease, you need to have a mechanism for continuing to monitor and sustain that elimination. So I would like to actually ask all our panelists sort of integration, first of all, how do we do it? What are the challenges? How do you integrate NTD elimination programs where the basic primary healthcare system is extremely weak? So I would like to ask for perspectives from a national perspective from you, Claire, from a UN global perspective from you, Onome, and then back to you, Solomon, as some of my colleagues are tend to see a seasoned participant in the discussion around health systems. I want to come back to you again to actually put your challenge back to you. But I'll start with you, Claire. At a national level, you've already started talking to us about what Tanzania is doing, but give us a little bit more, sort of, if you were to share your learning with partners, neighboring countries that are a bit further behind in the journey towards integration. What are the challenges? What are the opportunities?
Thank you very much, Dr. Okereke. Hopefully I pronounced your name correctly. So with Tanzanian experience, when you're talking of integration and looking at what is happening right now, this word has really become very popular among in the NTD space, because everyone is talking about integration, everyone is talking about integration needs. Integration brings about cost effectiveness, efficiency, and strengthening the health system. And in this era where we are observing the shift in funding space, we have used integration as one area to mitigate the gap which has been created. For instance, in Tanzania recently, in June, we did an integrated MDA where we integrated MDA for trachoma, soil transmitted helminths with vitamin A campaign. And this was more of a hybrid intervention, because you have to do it looking at how nutrition or vitamin A campaign are implemented, then you have also to follow that channel. So we ended up using all the three models. We did community MDA, we did fixed point MDA, and we did school MDA, because we were integrating three different interventions at once. So now, regardless of these ambitious targets of really attaining this goal, there are challenges. Integration comes with a number of challenges. With our experience, one of the main obstacles or challenge we faced was coordinating across these different traditional siloed programs. You have a nutrition program here, which is usually like vitamin A supplementation, which is usually done at the health facility. And now you want to leverage, it's not mostly integrating, but rather leveraging on the available resources. So when we were integrating NTD mass reg administration, like soil transmitted helminths, albendazole, with the vitamin A campaign, we experienced a lot of hurdles in terms of planning, aligning target population, timing, and resources as well. Because you are going to go to an intervention which probably, for instance, vitamin A supplementation targets children under 5. And you want to integrate with an intervention with a different target population. So just bringing about that coordination is a problem of itself. And another hurdle was the training requirement for staff on multiple intervention. It's also complex, because it demands more time, comprehensive modules. If you are going to be using the health facility model, that means you have to train all health providers at that particular health facility to provide all the services at once. And it's also managing the diverse supply chain of different drugs and supplements can also present a logistical hurdle. We experienced that one. But another thing, when we are implementing this intervention, especially the preventive chemotherapy for NTDs, we are dealing with the communities which are perceived to be healthy. So when you experience, because we experience the longer client interaction times, that means people are perceiving it like it's taking longer while they have other business to do, they are not sick. So it's really one area which we might look at improving. And also, another challenge was flexibility in terms of funding. So those are the areas, the challenges we had. One area was the flexibility and support across different programs, as well as partners who are supporting these interventions. How do they agree to relocating funding to be able to integrate other interventions which are not funded? Back to you.
Yeah, so thank you. So my reading of what you're saying is that it's not straightforward, and you have to really think it through and plan as much as possible in order for the integration to actually be an advantage rather than a challenge. And taking that question to you, Onome, the UN, like I said, a lot of UNICEF in particular has particular expertise in logistics for public health emergencies and routine activities. So how do you see yourself supporting member states, national governments to address some of these challenges that Dr. Clara has just articulated to enable integration to happen? You run WASH programs, nutrition programs, immunization programs. How do we do how are you integrating, and therefore how are you able to support national level to integrate?
Thank you very much, Dr. Ebere.
And just before you answer, if I might interrupt, just to encourage the panelists, there are lots of questions on the Q&A, and if you have a look and there's one you want to answer live, just type in your response there, so that because we might not have a chance to get to all of them. But please continue, Onome. Apologies.
So thank you very much, Dr. Ebere. I think short answer, how well are we? I'm re-asking myself the question, how well are we integrating? We could probably do a lot better. When I went to medical school, I keep thinking about that time. It was one human being. It was not one disease area necessarily, but it was that whole human being who is part of a household, who is ultimately part of a community. And so it was whole health. And as Dr. Sultani was speaking, he talked about the cycle of poverty and disease. And I remember the middle piece when we were taught was poverty, ignorance, and disease. And so as a UN, we've slowly and over time come to reinforce the fact that it is about strengthening primary healthcare systems holistically, because within that you can provide that package of services that are needed. I was looking ahead of this conversation, looking at different countries and their essential packages of care. And you do not necessarily see the NTDs as being part of that minimum package of health services or essential package of care. And in my mind, I was saying to this house, you know, what is my, going again to some of the questions, in 5 years, we should be trying to find a way to get that get some of these NTDs into the essential package of care. But there are multiple platforms within what we do, wherein we can better integrate NTDs. The immunization sessions themselves, it's not just the campaigns, health promotion, the water hygiene and sanitation systems. I remember there was a rapid drive around ensuring that we had wash systems in place to respond to the COVID emergency. But then how well did we use those systems that were left behind thereafter? And I think that's a massively missed opportunity. There were even Veronica buckets everywhere you go. Those things were all over the place. How didn't we overlay in those conversations? Wash your hands, wash your faces, do not touch your faces because you're trying to make sure you don't get COVID. But there have been all these other neglected tropical diseases as well. So in my opinion, not very well, but it still all sits with primary health care. And that's what we are pushing. Thank you.
It does. Thank you very much. And I'm going to make this the last question that I'm posing to the panelists, because there's so many really interesting looking questions in the Q&A that we'd like to get to and to give you the opportunity to address them. But Salman, I wanted to focus, because we've talked about, you know, countries stepping up, taking responsibility, expanding their fiscal space through domestic resource mobilization. But we're not in any way suggesting that donor funding is no longer needed. We know that we still need to do donor funding. So as the CEO of the End Fund, you work with donors, philanthropies, private sector, global, not domestic, but you implement through enabling and empowering national governments, ministries of health, and wider to deliver on the programs for elimination. So what are the mechanisms, what are the conditions that make co-financing as you deliver it, and say how it's operated through the Reaching the Last Mile Fund, for example? What are the conditions that make this work? How do we make sure that in this pivotal moment we've been talking about, that we optimize those conditions, we articulate what those positions are so that they can happen?
Well, thank you. Thanks, Dr. Barry, once again. Before we transit to that, I'll just do one quick thing on integration, if you don't mind. You know, and it's just a comment in the sense that it's very disturbing. What integration shows up every time we stressed on something, every time there's a challenge there. And we've seen this, I mean, using the seasoned person tag that you gave me earlier on. We've seen this on all sorts of global programs, all the way going back to PEPFAR for HIV, and then TB integration and COVID integration, and, you know, NTD integration now for this purpose. But could you imagine, and I think Onome said it best, if you took that cumulative effect of every stovepipe or every vertical structure that we put in place, and we tallied up all of that, and we looked at this, integration of health services should already be the norm. It shouldn't be something that we think about when we're confronted with some type of global challenge or local challenge. So I just wanted to put that in there, and because integration also takes a sustained level of resourcing in order to build provision of these programs to everyone. I don't think of any health provider or community health worker that will love to turn away the mother when the mother comes for the child care. So it's really something that we need to start not thinking about when it would challenge or there's a crisis there, but really piggybacking primary healthcare and all those platforms that we've been universal healthcare, really making it part of our day-to-day programming as opposed to a solution to a crisis. And I just wanted to put that as a quick thing before I move on to the co-financing piece. And you've made the point quite effectively. The challenge is huge. It's big. It's not just, we're not swinging the pendulum from ODA and global assistance to the continent or the African continent or the member states picking up the full, bill for what we're supposed to be introducing for the future. As we start looking at, what is already in the system, efficiency has been mentioned a couple of times with Dr. Clara as well. We really need to look at the efficiency of this. Is simply increasing domestic resource going to solve our problem? I don't think so. We can put in all the domestic resources and all of the global assistance in one bucket, and if we don't do things differently, and we don't really eliminate duplication, and we're not laser focused, then we'll just waste resources and not necessarily solve a problem. So co-financing comes into that space where we really want to leverage efforts on the end fund side, leverage efforts that any system in a country generates, whether it's domestic resource mobilization or increasing that from government sources, or the corporate sector stepping in and saying, we would like to do on this co-financing matching opportunity here. The end fund is already being able to do that. And we have examples. We have examples in Kwale County in Kenya where we've match funded. We have examples in the Oromia region, where one of the regions out of the state, out of the federal government actually, had a matching, fund matching opportunity there, where the federal government now steps in and says, can we subsidize smaller regions that don't particularly have the resources to do that out of their regional budget? So it is moving, it's catalyzing. There are high net worth individuals that are, again, interested in really looking at what kind of investment they can put into their countries. The Masiwas are one example that very much can be highlighted in Zimbabwe. But the whole thing that I want to bring forward is really understanding what we're solving for, having a very clear division of labor, and really stretching the penny. NTDs, like a good colleague of ours says, has always been working off of scraps. It hasn't been the well-financed, the abundant resources coming to the NTDs sector. So we are already, in a sense, when you look at leveraging community health workers, leveraging existing, delivery platforms, we're already integrated. And that's one of the strengths and really coming in and not duplicating efforts and really focusing in proven partners to actually implement this. And I shout out to Amref, not because we think he's here and he's going to chase after me and beat me up for not saying something good about him. But I really respect this kind of platform and really making sure that we look at opportunities here holistically, and going back to that cumulative effect. This health system strengthening that we did in PEPFAR 20 years out. If you imagine how much dividend they would have gotten by now when we're talking about NTD. The work that went into COVID, again, out there, massive amount of investment went into it. So it's time for us to start rethinking how we use resources, not just how we just collect the resources.
Absolutely. Thank you. Thank you very much for that very comprehensive reflection. So in this, our panelists have articulated the success stories. We recognize that we have eliminated a significant number of neglected diseases, and that effort is to be acknowledged. Congratulations are due. Some countries have already started ahead of the current crisis to look at how we continue to integrate neglected diseases into the routine health system, recognizing that foundational to the management of any public health challenge is got to be a functional health system grounded on primary health care. We've acknowledged the failures to leverage opportunities to learn from past events, to coordinate, to actually move from our vertical to horizontal systems earlier than this, and acknowledge that we need to also address efficiencies. Solomon touched on the innovative approaches to financing, how we can actually co-finance with those donors so that we recognize the impact of investment in NTDs. But I was at the GAN Accra Summit just a few days ago, and there was a focus on governance, and the message that stuck with me was one plan, one investment pathway, one set of priorities. And I think that same message resonates for the conversation here. And so I'd like to thank the panelists, but please don't go away. Gitinji is going to pick up the questions that the audience have put on, and we'll keep going from there. If you've been able to answer any question by typing into the answers there, that's really great. We appreciate that, but we'll pick up as many of those as we can. So back to you, Gitinji. Thank you.
Wow, thank you very much. What a fantastic panel that we've had there. Thank you, Ebere. Thanks to the panelists. And I can just say congratulations. I can tell you that I've been watching the Q&A, and the timeline is moving fast. It's difficult to even capture the questions. There are so many of them. So I'll try and just capture some of them holistically. And actually, I will start with you, Ebere, because I think one of the questions I saw is on reaching last mile. And the question is, how are your investments, if you're able to talk about this, going to address the issue of local surveillance and the MDA delivery? If there is anything you can respond on that.
Gladly, and I will be short because I think the panelists also have much to say there. The model that Reaching the Last Mile Fund has taken across the board in its investments for NTDs is one of co-creation and co-investment. So because that is what we see as a foundation to sustainability. The fund's commitment is until 2030 at this phase. We recognize that no matter the financial category of the country, there is something they can bring. So our funding model is such that we fund, but we expect the country to also step up. And we already have some RLMF partner countries that have done that. Tanzania has been mentioned, Sierra Leone, Liberia have already stepped up and said, we will contribute this percentage into what the budget is for this year to work on NTDs. Also, we're looking at things like how do we build up capacity that will continue to impact beyond the elimination agenda in terms of like training, expertise that isn't just for the diseases we invest in, but will actually be relevant to other health priorities in those regions that we work in. So in everything we do, there is an expectation and encouragement for countries to effectively, to put it crudely, put their money where their mouth is. So if we are going to come in, we look to you to also step up and come in. And that is actually a particular challenge we recognize when you're grappling with other priorities and sort of acknowledging what Onome said at the other time, that there has to be some sort of prioritization. And we recognize that.
Thank you. Thank you very, very much. And just to reflect on the question you were discussing earlier, and that many of you addressed, and Solomon actually tried to talk about in terms of this term integration. As you've heard from Clara, it's not as simple as saying, let's integrate. I think how we do that should be probably just having a people-centered health system, as was said earlier by Onome, that we don't look at the health system, we look at the people, and then we apply the health system of the people rather than the people to the health system, which has, so I think it needs a kind of a whole reset of how we plan, but it's not easy. So Clara, there are a few questions around number one, and maybe I'll ask you directly from a Tanzania point of view. How are you in the government engaging youth and young professionals in this area? And also, how are you ensuring that NTDs reach the rural communities that are most unreached, which is also now about community engagement. So maybe you could capture those two together. And then I'll come to you, Nome, because there's a question on supply chain. And I know UNICEF is big on supply chain. And the question here is, do we have any plans or efforts to put to place or to strengthen supply chain systems for NTDs? You could quickly comment on that. So over to you, Clara.
Okay, thank you very much, Dr. Githai, for that two quick questions. One is on how, as the program, as the country, we are engaging youth in these. Actually, as a nation, we developed advocacy strategy with different groups. So we do have those special groups, like, apart from youth, we also have those population with different characteristics, like nomads and everything. So we have this advocacy strategy targeting specific groups depending on what exactly they are suffering from. We also work closely with school programs, because we understand when you impart knowledge at the very early stage, that means you are more likely to develop a culture where people understand the NTDs, knows what they're supposed to do, and then they can as well change the environment. We are working really close on these school programs together with Helen Keller, who are supporting the school programs to ensure that NTD is well known from the very early stage. And also, as the program, we are also working with other youth groups. There are a number of youth groups in the country which are championing on NTD interventions. So we work really closer with them, give them the materials they need to be able to do the advocacy and the outreach. So that is how we are engaging the youth. And also during the provision of these services, knowing that we do have, we usually do community work. So mostly we are enrolling youth who are more likely to reach other youth and also to increase their acceptability. So we are really working closer with the youth, and they are being part and parcel from advocates, behavioral change information, and then we're also developing these education materials which are tailored to this group so that they can as well be part of these interventions. And on the second question was, how do we reach the community who are more vulnerable? Yeah, so reaching the community who are more vulnerable, it's really one thing on the implementation of the program. We are more lucky that we have adopted the CDTI approach, which has been in place more than 30 years ago. And this is community directed treatment with ivermectin. So we took this approach, the CDTI approach, and so whenever we are doing a community-based intervention, we usually put the community on the center. They are part in planning as well as implementation. So this model, the CDTI, has been more like a pivot, or more like a pillar in the implementation, where community are part and parcel of this implementation. Thank you.
Thank you very much. Community-directed treatment approach. Thank you very much, because as you've heard and as I see on the program, on the comments, communities are at the center. So as we come to Onome, I am going to ask Solomon to prepare for the following on whether there are any initiatives that you've seen in all the areas you work that use digital technology, AI, or mobile health platforms that can actually be adopted as adaptation strategies for improving efficiency that you've seen elsewhere that can be scaled in different countries. And also whether there is any effort from the community of NTDs to invest in diagnostics. So I'll come back to you shortly, Solomon, but over to you, Nome, on supply chains.
Thank you very much for the question. Indeed, the supply chain for NTDs, from a UNICEF standpoint, would be the way we focus on strengthening supply chain systems for all primary healthcare commodities. Of course, vaccines have their peculiarities, but chemotherapeutics, dry goods, have standard supply chains. It all boils down to the decision of the index country. And of course, we align behind country plans. The decision of the index country around integration in the first place at that governmental MDA level. And we talk about functional and programmatic integration. So programmatic integration from that standpoint, there are multiple levels in the supply chain process end to end where we could say we could strengthen the supply chain for NTDs. It could be integrated planning. So it could be that at a government level, we have an integrated planning process, a forecasting and a supply plan development process. It might just be that. And you'd have ticked a major box from a supply chain perspective as it relates to NTDs. It could obviously dovetail into the procurement of these dry commodities. It could dovetail into the storage. So the dry storage of these commodities at different levels of the supply chains. There are some countries that have integrated storage of their health commodities, which could also include NTDs, the Ethiopias of this world coming to mind. And there are other countries that continue to have siloed systems for storage, which of course throws out the efficiency argument. In the same vein, the distribution of these commodities, especially as we have dry goods that get distributed. With the vaccines, you have the vaccines themselves, but they tend to have related dry commodities. You could easily distribute your NTD, your chemotherapeutics, even the diagnostic kits with those dry goods as well. And ultimately how the waste is managed. So that's the disposal of the waste products or whatever services are rendered is also part of that whole endpoint of the supply chain management. That could also be done with NTDs, for NTDs within broader primary healthcare programs. But the decision starts first with what is the government's approach to managing its system, which again takes me right back to having a primary healthcare lens as opposed to a siloed programming lens. Thank you.
Thank you very much. And I think one of the questions that I saw is how countries can learn from each other. Because the things you're talking about is at the bottom of this, at the foundation of this, is country leadership and country ownership. And there are many areas of countries, those countries that have eliminated NTDs, there are certain things that they have done. And these things are around, number one, it's strong political will and country leadership. And that country leadership is both national, regional, or district. When I listen to Clara, I hear a lot of municipal level, local level. So there's that one bucket of activities, strong political will and country ownership. The next thing is integrated and multi-sectoral approaches, which we haven't talked a lot about, how we bring in the WASH community, veterinarians into this, and how do we bring in water, sanitation, and hygiene, and education, and all these things that address this matter. And finally, public-private partnerships and community engagement, which is what you're talking about. So many of the questions are also around these areas. So the first thing I want to ask Clara after Solomon is for you to think about what opportunity exists for countries to learn from each other and to share. We know there are declarations at WHO level. There's a declaration in Kigali. There is also the Africa Union declaration on NTDs. But those are declarations, and I know I have been involved in many declarations in the past, and many of them leave their life history on the shelf. So practically, how is Tanzania learning from any other country, or is Tanzania sharing with other countries? But let me come to Solomon on the issue of technology and tools.
Okay, great. My unmute button wouldn't work, sorry. So they can talking about technology.
Exactly.
So digital and AI. I'll preface by saying that this is an evolving space. And our guest speaker earlier on mentioned how research and technology going into the NTD space is not necessarily a big return on investment when it comes from an investment standpoint. Therefore, it's not surprising that there aren't that many AI and digital activities happening in the NTD space. But that being said, there are some, sparse investments out there that I know of in like cutaneous NTD disease progression exercising that's being modeled out there. But I can potentially talk about the future applications of this in the face of efficiencies once and for all. Mechanizing was a number one efficiency in the industrial moment, and then now digitization was another efficiency tool, and now AI is also looked at as an efficiency tool as we move forward. So in this evolving space, efficiency tools, I see them being very much applicable, not just for the NTD space, but for health data collection in data analysis. Really setting up the trend in disease elimination for us is a big concern, and we'd like to particularly start looking at how we can work our way back from an elimination deadline, a timeline, and work our way back and see what kind of tools we can use, data assisted and AI assisted. Mapping is another one. Endemicity, mapping in the face of climate change. This was mentioned early on. Vector-borne diseases or vector-transmitted diseases have a tendency now in the climate space to be found in places where they did not exist, which kind of increases our risk of elimination by the time we intended to do it. One that has come up, and I think Dr. Clara is probably going to be mentioning this as well, is surveillance. Surveillance specifically post-elimination. As we were discussing over the 4 days at the African Union, post-elimination, or countries that had eliminated diseases expressed their concern around surveillance and cross-border surveillance. Understanding that we have some flies that can fly 400 kilometers and don't particularly require visas to go across the border. Eliminating in a particular geography doesn't necessarily give us the assurance that we have eliminated the disease in the region, as long as we can't do that on a regional scale. So in that area, AI-assisted mapping, surveillance opportunities, I think with digitally supported opportunities is something that we can really consider and are looking into. So the good thing is there's massive investment, as everybody knows, in AI. How do we channel it into making it for NTD purposes? But if we look at integration as well, how do we leverage other resources that are being put into a different disease pattern for us to benefit from the NTD so that we don't replicate or duplicate efforts is one. And you asked me a second question, which I forgot to jot down.
It was on diagnostics tools, whether there is any pipeline of diagnostic tools. Yeah.
It's so diagnostic tools, none that I can think of, but that's not for lack of pushing. We will have to continue to push the sector to see if there are, mostly patent that are potentially or technology that could be transferred without necessarily being developed for the purpose of return. So that takes us back to our philanthropy donors, where we, if we can do the case, we can provide the effective case, then we can convince them to do into some diagnostic space. But let me take you back to what you said, Genji. The multi-sectoral approach of this is the most common sense driven approach. The water and sanitation piece, when we look at where NTDs were eliminated in the global north and all the tools that we have right now, it dials back to saying it's not a pursuit of sophistication. It's a pursuit of rigor. It's a pursuit of really paying attention to what the resources that we have now in order to put a big dent on NTDs. Water sanitation is across the board. It's not just about NTDs. It's maternal child health mortality. It's nutrition related. It's stunting related. So as we start looking at these, I don't particularly see us pushing for a greater diagnostic tool in NTDs, and more of a community-based, awareness, a community-centered, and a community ownership, as opposed to the broader country ownership that we're talking about. Because where the road meets the rubber meets the road is at that community level. And if we can change behavioral there, and we can inject that rigor into, the water and sanitation not being 9 days out of 10, but 10 days out of 10, because you don't want to infect yourself on that one day that you slip off. So I'd like to inject in there, DTNG, the idea of really sticking to the basics and really being thorough and rigorous about what are the resources that we have now in education, in water and sanitation, and all the other assets out there to really put a comprehensive approach to engaging NTD elimination.
Thank you. Thank you very much. And I think as we come to the end of this Q&A session, because I would like to hand over to Ebere to do some closing remarks, I would just like to hear from Clara first on this country learning, because again, it's back to what Solomon is saying and others about the simplicity of this thing. There's a country that's doing well, but there's maybe you just need $1 to share that good invention with our country and save so many dollars elsewhere. But we are kind of in Africa working in silos. But I'm looking forward to Clara providing us hope that countries are actually learning from each other and sharing. Over to you, Clara.
Okay, thank you very much, Gitai. Actually, we are learning a lot. There are a lot of things which are happening and which actually brings the managers and the countries together. One of it is we do have this group called Kikundi, and it's for program managers in the country, in Africa, where program managers come together, share experience, and at times they are site visit. If there is a country where they are doing really well, then there is a visit which is organized by the Kikundi, and they visit and learn from what this country is doing. But also we have had other platforms. For instance, this recently launched GONE, which I happened to be the vice chair up until last year. This has been bringing together country, but this is more specifically for Nkosekasisi. It has been bringing together country focal point for Nkosekasisi, sharing their experience, progress, challenges, and these webinars, it's through webinars. So these webinars are organized on time basis and looking at what that country can provide to other countries for them to learn, and it's really working well. And also we do have this ESPEN, which is expanded special program for the elimination of NTDs under the WHO. This through ESPEN, we are learning a lot because most countries do share their reports there. Each country report is there. So if you want to see what is happening in other countries, you can just go through this ESPEN portal, and then you'll see. And if you need to learn more, then because you see what are the progress of each country, then you are more likely to reach out to the country to see exactly where you can learn. So there are other platforms like NTD manager meetings, which are convened annually, which brings about all managers, NTD managers to discuss, share experience, and also learn from each other. So we also have these meetings convened by CDC, Afro. So there are a lot of areas where we are learning. And indeed, we are learning a lot. Because at times, if you see there is progress in one country, the organizers will reach out to that country, ask them to come and share the experience and give the opportunity for other countries to ask. And in this forum, we usually have the partners as well. So you hear from the country point of view, and also you have an opportunity to hear from partners, either partners supporting that specific countries or other partners who are also interested in that specific area. So we do have areas actually, and we are learning a lot. Thank you.
Thank you. That's actually more than I thought and more than I expected. So very, very impressed. So we'll look out for Kikundi. We'll look at, and you can share some of these with us, and we can share some of these platforms, more widely. Colleagues, as we come to an end, I just want to make some concluding remarks before I hand over to Ebere. The first thing I want to say is we just came out of Accra this last week, and the meeting in Accra was discussing Africa's sovereignty, health sovereignty. It was a summit convened by President Mahama. Some of us were there. I was there at least with Ebere, I think, and Solomon, I think, Enfand, I think it was represented. But the whole idea was that we need health sovereignty in the continent, but we're raising the point that financial sovereignty does not necessarily translate to program sovereignty. And I think that's what people need to realize, that the countries first need to honor the program and have program sovereignty so that you achieve financial sovereignty. If you just want to achieve financial sovereignty, I want to make the point that we already have it, because 70%, 80% of our financing in a country, at least the ones that are not conflict states or the ones that are not, extremely poor, Tanzania, Kenya, Uganda, and others, 80% of the health financing is actually domestic. Never mind, it's not purely publicly funded, which is the problem. It is a combination of public and out of pocket, which is a disaster. But at least 80% of the money funding finance in Tanzania is sovereign. from the people and the government. So we don't have financial sovereignty. What we don't have is the effectiveness of the program sovereignty, so that we drive the other 20% that is coming from our partners, which is inevitable. We are not talking about an Africa without aid. We are talking about an Africa that where the aid is integrated in a program that's led by the country. Because why? Because if I saw somebody, I think it's there's somebody who asked a question. Christine Gillan talked about, why can't Africa promise the donor that will fund 70% of the health? It's already doing so. What it needs to do is organize the 70 to be publicly funded, so that we don't burden poor communities without out-of-pocket expenditure. But let me give you a quick statistic, and then I'll keep quiet. That when we focus on 15% Abuja, there's a difference between 15% of a chicken and 15% of an elephant.
A cow.
And what Africa has is 15% of a chicken. Why so? It doesn't matter how much tax we collect from our governments. It doesn't matter, because we have a demographic and economic crisis. Our population is large and our GDP is low. That is taxable GDP. To give you an example, Germany alone is 86 million people, but Germany has twice the GDP of Africa with 1.4 billion people. So when you look at the mathematics of Africa, with 1.4 billion people, with only half of what Germany has with 86 million, achieving 15% is not enough. Actually, when you do the math, 15% of best taxation with the government and best expenditure, no corruption, will give you $50 per person per year, whereas Germany is spending $4,000 per person per year. So we have to eliminate NTDs from eliminating neglect of people as well. We have to focus on the multi-sectoral areas. We have to give water, clean water, sanitation, food. We have to create economic empowerment, so that we eliminate the NTDs together with eliminating the neglect of our people. So it's not just about 15% that I've seen people talk about. It's about reformatting the health system to be preventative, to be promotive, and to be productive of health, not curative of disease. Over to you, Ebere.
Thank you. And I would add one last comment to that barnstorming summary, is that one of the best investments to address poverty and therefore neglected tropical diseases is to invest in women. Women education, women economic empowerment moves communities out of poverty. So we'll add that to the agenda that we will be advocating for, which is beyond specific diseases, but like you say, it's about moving our population out of poverty into affluence. Right, so thank you very much, Gitinji. So the purpose of this session today was actually to celebrate, first and foremost, the successes that we've achieved in eliminating some neglected tropical diseases, is to raise awareness amongst all of you here and to the people that you represent and your constituencies about the opportunities to continue to drive towards NTD elimination, and then to recognize the challenges that we face and what the opportunities are to address them. So I believe personally that NTDs have the potential to be a success story for the 21st century. We're already beginning to see signs of that. And that success is within our reach and is cost effective. But we also recognize that, as Gitinji just summarized, these are diseases of poverty. So success requires addressing poverty. We need to look at the wider determinants of health, as well as basing everything on a well-funded and accessible primary healthcare system. Now, there have been missed opportunities in the past to learn from previous opportunities. We need to remember, because we keep talking about the constrained fiscal space here, we eliminated smallpox, eradicated smallpox worldwide in the middle of the Cold War, and coming out of a Second World War where the economies were collapsing and just about recovering. So if we've done it before, we can do it again. I believe very strongly that we welcome that donors continue to support our countries and accept, and we recognize that countries need to actually meet donors halfway. If anything, my view, countries should be in the front. They should be setting up the plan, defining their priorities, identifying what resources they have, and donors act as complementary to that fact. We have to learn from those countries that have been successful. We've heard really eloquently about the experience in Tanzania. The other countries, Senegal, Mali, Niger has been mentioned, who have had recent successes as well. We need to continue to use those tools that Dr. Clara defined to learn from each other. I could go on about what else we've learned here, but I'm going to suggest that if you want to know more about NTD elimination, please visit the Escape the Neglect DevEx initiative on DevEx. It gives you a lot of information about what's happening, what the progress are, what the opportunities are. And I would encourage you to share this information. I understand from the organizers that this is recorded. The recording will be available. Share that, listen to it again. Look at the questions, because some of the questions are very insightful, and the questioners have answered some of those questions. So please have a look at that. Right, I would like to close by thanking the Gates Foundation who supported this, Amref who hosted it, coordinated it, and given me the opportunity to pass time in a very exciting way with colleagues that I'm privileged to meet, new colleagues that I hope to continue to work with. I'd like to thank our keynote speaker, Dr. Sultani, the Deputy Director of the Ministry of Health in Kenya, for joining us and his very reflective comments at the beginning of this session. All our panelists, Dr. Clara, Dr. Solomon, Onome, thank you for your insights and for your very open and reflective comments all through. I would like to end by actually posing a question to all of us, not one that I expect us to answer here. If we meet again in 2030, I know we will meet many times before then, but if we were to convene this gathering again in 2030, what will we need to have seen to have changed in how Africa is leading, delivering, and financing the agenda to eliminate neglected tropical diseases? I think we should put that goal, what we want to see, as the goal and work backwards from that. 2030 is only 5 years away. What do we need to see for the narrative to be different? And so for me, thank you very much for the privilege and the opportunity. Thank you, most importantly, to all of you who dialed in. And hopefully we've learned a lot, and we will continue to share our learning going forward. Thank you very much. Thanks to the people behind the scenes as well. Thank you.
Thank you very much, Ebere. So as we conclude, I have seen a very upset Jimo Dare, because he says that we have not named NTDs specifically and given their data. And I want to tell Jimo, this was deliberate. We are talking about cross-horizontal systems that address every single NTD. And that reflects also the research, Africa-led research, to see exactly what's happening where. So the research agenda for Africa for NTDs is an important one and I shouldn't leave. Finally, to say, I've seen someone say, are we not advocating for a donor-free Africa? A donor-free Africa is a disease-free Africa. It's an Africa that has actually produced health. So on that journey, we will not be alone. As Kagame said, the fact because we do it ourselves does not mean we do it alone. Even in rich countries, there are vulnerable populations that are donor aided, even in America, even in Europe. So the most vulnerable must be supported by all, whether they're in Africa or in Europe or in Asia. So we are talking about doing it ourselves, but not doing it alone. Thank you, everybody. Yeah. Thank you, Ebere, for moderating. Thank you for the panelists, Dr. Sultani, who was here earlier, and to all of you who joined. And the team was behind this. Thank you. Bye-bye.
Thank you. Bye.
Bye-bye.